not connecting correctly. Saying it's trying to go live.
Purple cast.
Showing off the purple cast. Okay, you're live.
Okay, hi, good morning everyone. Welcome to Midwife Monday. I hope everybody had a great weekend. I broke my wrist. So we have that going on, which is very exciting. Broke my wrist, broke my fingers. One finger. But healing well. So today, hey, we're going to talk about the due date, this myth of a due date. I know we've done a blog on this before, and we did on our IG account, which is SCV Birth. We did a little meme on this due date, and we got a lot of comments on due dates. So I just want to dispel a little bit of what does this due date mean? What does it mean? So what we know is that most women will gestate between 37 and 42 weeks in their pregnancy. That is a full-term normal pregnancy. In the U.S., we get really attached to that due date that we're given, which we work out that number based on the first day of your last period. Or sometimes we will identify it by an early ultrasound, which is really pretty accurate, actually. Early ultrasounds are pretty good at estimating due dates. It doesn't mean that's the day your baby's going to arrive. It just means that that date gives us a pretty good 5-week window of when your baby might arrive. There's something called Nagel's rule, and that's how we determine the number of days you will gestate. I think it's like 265 days. Is that right, Kitty? Do you remember? I think it's 265 days is from the first day of your last period. We know that most women will have a baby sometime in there. So the problem is that we really get attached to this number, to this one particular date, and it causes some anxiety as we get towards the end of our pregnancy. When's the baby going to come? When's the baby going to come? When's the baby going to come? And it often results in the medical model of care with an induction of labor. Many obstetricians will start talking about inducing your labor at the 40-week mark. Like, well, we still haven't had a baby, so maybe in the next couple of days, we're going to have you come in for an induction. Most really like you to be induced by 41 weeks. When you're with a midwife in an out-of-hospital setting, we don't do anything. We know that a baby will probably come by 42 weeks, which is normal. Now, there are things that we do towards the end of the pregnancy to make sure that it is safe for you to continue to be pregnant. But what's really important to remember is that for first-time moms, we expect first-time moms to go 7 to 10 days post-dates. So we try to tell everyone, say your due date is April 1, we want you to tell everyone you're due April 15, right? Give everyone your 42-week mark date in your world, like all your family and your friends. Tell them you're due in 42 weeks. But that's the date you were given, because the stress of living in your daily environment, that constant question of, oh my gosh, you're still here. Oh my gosh, you're so big. Oh my gosh, you look like you're ready to pop. Do you have twins in there? I was never that big. When are you going to have that baby? You're still walking around. Oh my gosh, have you seen a real doctor? That's something that people say when you're with a midwife. We love that one. My doctor never let me go past X, Y, and Z. Oh my gosh. And, you'll be in the shower and somebody will text you and, it takes you 20 minutes to respond and everyone is convinced you've had the baby. And, oh my gosh, you didn't call me back. I thought you were having the baby. And there's a lot of pressure towards the end of your pregnancy to, like, when is this baby going to come? And so your stress level starts to go up, which, by the way, inhibits your labor. Because we know the more adrenaline you produce, the less oxytocin you produce, the more you try to get yourself into labor, the less likely it's going to happen. So we say we know that these babies are going to show up sometime between 37 and 42, and most likely closer to 42. There's a saying, Michel Audant is a famous obstetrician who speaks globally and has done lots of research, and he's a very well-respected obstetrician from France. And he says not all the fruit ripens on the same day, right? So you have a lemon tree in your backyard right now, and there's lots of lemons on that lemon tree. Some are falling, and some aren't. So just because, trees and fruit, we don't have a day that they're due. We have a season that they're due. Fruit ripens in a season. You might have a long season or a short season, like cherry season, for instance. It's a really short season, but we know that we're going to be able to pick cherries in this, 4-week window. And some of those cherries are going to be fresh, ready to pick at the beginning of the season. Some are going to go all the way to the end of the season. So think of your pregnancy due date as your season of when your baby's going to be born. Again, there's this 5-week season for when it's normal for babies to be born. And there still are some outliers. There are some women that gestate very quickly, that will have a baby at, they're called late preterm, like a 36 and 4, 36 and 5 days. We don't do those births here at the birth center. The law in California says we can catch babies between 37 and 42 weeks. So we know that that's a full term. That's what the Medical Board of California says is normal gestation. And we still have some women that will go past 42 weeks. And as long as the environment, right, there's post-dates testing that's recommended and that we encourage everyone to do, starting at 41 weeks, we start looking at the environment with an ultrasound, measuring how much amniotic fluid is in there. How does that placenta look? Is the baby reactive on a non-stress test? Those are indicators once you get to 41 weeks whether you can remain pregnant. Excuse me. So we do those post-dates testing. Our recommendation here at the Santa Clarita Birth Center is that we start those at 41 weeks and we repeat your post-dates testing every 3 days until A, you go into labor spontaneously, B, we identify that the environment is no longer optimal to remain pregnant and an induction is recommended. It's really rare in our practice. Again, we're not talking about, we don't do 500 births a month. We're still working in very small numbers. We do about, 10 to 12 births a month here. And it's very, very rare for a woman to get to a point where she has to be induced because of her amniotic fluid is low. It does happen. It has happened. We do have it once in a while. We don't have it that often. So for instance, right now we have a mom in our care who's 41 weeks and 5 days. She's really wanting to have her baby. And we all agree it's a pretty good time to have your baby. She has gotten post-dates testing. She has been doing collaborative care with an obstetrician. Not so evidence-based, where they started her post-dates testing at 40 weeks, which that's not actually what the evidence says. The evidence says start at 41 weeks. So she's been going in for, measuring her amniotic fluid, doing a non-stress test, doing what's called a biophysical profile. And this baby has been, scoring perfect, 10 out of 10, 10 out of 10. This baby's doing great, plenty of fluid, baby's reactive. So we go 3 more days and 3 more days and 3 more days. And every time she goes into her particular provider that's doing this post-dates testing, every time she goes in, they say, you need to be induced, you need to be induced, you need to be induced. But there is no medical indication for the induction. So there's very specific criteria that we're looking at when you go past 41 weeks or you hit the 41-week mark. Very specifically, we're measuring the amniotic fluid with this ultrasound, right? So your uterus is marked into quadrants. So 2 top, 2 bottom, right? 4 quadrants. And the technician or the obstetrician or the radiologist who's ever doing your testing, right, they're measuring these pockets of fluid. And we're looking to get a total amniotic fluid index of 5 or above. And we're also putting a mom on, we don't do it here, we refer out for that testing. We work with some wonderful perinatologists, we work with some wonderful obstetricians in hospital and out of hospital that will do that testing for us. But we choose not to do it here at the birth center because we like to have a third party, a more objective person to make sure that what we're seeing is true. And so we send out for those. We do have a tech that comes here and sends it to her doctor to read, but as the midwives here in the birth center, we don't do them. So when this is done to you, right, they're measuring your amniotic fluid index. They're also putting a monitor on the baby, and they're looking at the baby for 20-minute segments to make sure that your baby's heart rate is reactive, to make sure that there's good accelerations in this baby's heart rate, that the baby's not staying, what we say, flat, right? That the baby's not as non-reactive, and make sure the baby's not having any decelerations or any abnormalities at that point. Since you're not in labor, there's something that we expect to see. We expect to see a reactive baby on the monitor. So as long as we have a reactive baby, we have adequate amniotic fluid. That is not a subjective number. The American College of Obstetrics and Gynecology say that an amniotic fluid index 5 or below may be an inducible number. But if it's above 5, we don't induce. If you have an amniotic fluid that's 5 or 6, we'll often say go home, drink a bunch of water, get a gallon of water in, get at least, 1 liter of electrolytes, get a liter of coconut water, a liter of smart water, put electrolytes in your water, drink, super duper hydrate. We know you can affect your amniotic fluid by several points within a short amount of time if it's a hydration issue. Sometimes really what we're looking at is the integrity of your placenta. Placentas have a finite lifespan. They don't last forever. So we do the post-dates testing because we want to see that this placenta is still functioning well. And most women will spontaneously go into labor when everything is, kind of done. That placenta is done working, all the hormones are right with you and your baby, and you spontaneously go into labor. It's rare that a placenta, that will get to the point where the placenta is not functioning well. I mean, it can happen, and we say, the baby will do better outside the environment than in the environment, right? So amniotic fluid index is an indicator of how well your placenta is functioning. So if you have an amniotic fluid level of 5 or 6, we say, let's repeat that ultrasound in 24 hours, as long as the non-stress test is passing. This baby looks good, everything else looks good on the monitor, except the fluid level is at the low end of normal. We say, let's hydrate, repeat that ultrasound in 24 hours. If that number has gone down, we say, well, that must be a placental issue. It would be appropriate for an induction, and then we make arrangements for that. But if that number has increased, we know that it was possibly because the mother wasn't hydrated enough. Maybe you have a cold. Maybe you've had the flu. Maybe it's going to be 90 degrees. Like today, it's supposed to be like 91 degrees today here in Santa Clarita. So if you're out and about and you're trying to get your baby out and you're out all day walking, and you're not drinking enough water and your stress level is high, and then later this afternoon you go in for an amniotic fluid index and your number is 5, well, I don't know, was that a hydration issue or is it because your placenta is not functioning well? So let's give that 24 hours and take another look at it. We know we can actually retest that amniotic fluid index. I think it's within like 6 hours and we should see a change, but it's unlikely that you would be able to go back in later in the day, in that short a time to repeat your amniotic fluid index. So we say 24 hours is reasonable. So you're looking at your amniotic fluid index. So if you're with another healthcare provider, you're with possibly an obstetrician, you're having a baby in the hospital, and they say to you, well, we need to induce because your fluid is low. Well, what does that mean? You're allowed to ask that question. Well, what is my number? What is my amniotic fluid index? What is my number? Was there a large pocket? What's my number? And what are the other medical indications for my induction? Not just because you're post-dates. That is not a medical indication for an induction. There has to be criteria. So we strongly recommend that you use your voice and ask those questions. And of course, if there's criteria, we absolutely agree. Consent to an induction. That's going to be in your baby's best interest. And knowing that you may be consenting for an induction, which may very well be appropriate, also know, especially if you're a first-time mom, that induction, you're looking at a 2-day induction. Like, you're not going to go in and have your baby that afternoon, most likely. Most likely you're looking at a 36 to 48-hour induction before we have a baby, because it takes a little while to get that cervix to open, especially if, if your cervix isn't open. Right? There's something called a Bishop's score, and it's just like the word bishop, so it's a Bishop's score. So if you're going into an induction, you might ask your care provider, what is my Bishop score? Or perhaps you have a doula. Doulas are awesome at knowing all of this stuff as well. If you're not with a midwife and you're having a hospital delivery, we absolutely recommend that you get a doula, even if you are with a midwife. But in particular with an induction, having a hospital delivery, that doula can really help you stay well informed. And the question is, what is my Bishop's score? So what that is are you dilated? You get a certain amount of points for dilation. What position is your cervix in? Is it pointing posterior still, or is it anterior? Is it thin? I forget. So it's cervical dilation, position of the cervix, effacement of the cervix, station. How low is this baby in your pelvis? Those are part of a Bishop score. So the higher your Bishop score, the more successful your induction is going to be. But the lower that Bishop score, the less likely. And remember, we have about a 33% C-section rate in the state of California. So of those women that have had C-sections, the question is, how many of those were induced and what was their Bishop score going into this induction? What was the basis of the induction? Was it because we had some medical criteria, or was it just because the fruit wasn't ripe? So that's some language that can perhaps, help empower you a little bit if you're not with a care provider that is working out of hospital or necessarily evidence-based. But before you consent to an induction, what is the medical criteria? What is my amniotic fluid index? What is my Bishop score? If I do indeed need to be induced, what does that Bishop score look like? So you can have an anticipation of how many days it may take before you see your baby. If you have a very low Bishop score, you're going to have a very long induction, because we still have to get this cervix to shorten, the cervix has to move anteriorly, and it has to open, and this baby has to come down into the pelvis. There's a lot of things that have to happen, and that doesn't necessarily happen within 12 to 24 hours. So it will help you a little bit get your mind wrapped around what that induction might look like and have some realistic expectations. But do remember that not all babies arrive at the same time. So I will give you a little bit of an example of a mom that we just had who delivered beautifully. And according to the dates we were using, and coming up with those dates, so going back to what we talked about a little bit in the beginning, was there's something called Nagel's rule, or basing your due date on the first day of your last period. That's assuming you have a 28-day cycle, assuming you ovulated on day 14. Some women have 35-day cycles. Some women have irregular cycles and they might ovulate day 10. Some might ovulate day 21. So basing your due date on the first day of your last period is not always the way to go. Sometimes here at our birth center we'll look at conception, and then we still have some wiggle room within conception, right? Because, or when you were intimate, we actually don't know when conception happened. It can happen, you could be intimate and then not actually, the egg and the sperm might not match up there for maybe 2-3 days after intimacy, right? There's this window of how long the sperm can live prior to intimacy and after intimacy. So it doesn't always happen at that magic moment, right? So we're looking at, when did you ovulate? If there was an ultrasound done between like 8 and 12 weeks, that's a really good indicator of that 5-week window. It's a really good marker for dates. We don't always recommend that you do that early ultrasound because, you could do it if you want to do it, but sometimes we don't gather any information from it, especially if we have someone who cycles every 28 days. She's got a regular cycle. We know she ovulates day 14 or so. We don't need to do an ultrasound to confirm that she's pregnant because we already know what her normal cycle looks like. So my point, going back, so we have this mama. It's her 4th pregnancy. And her first 3 pregnancies, I have a history with her. I've been with her for her last 3 babies. But her first 3 babies all came about 40 weeks, give or take a day or 2, right? She always goes right around her dates. So 4th baby, irregular cycles. We kind of know when intimacy was. We do know when intimacy was. We did an ultrasound. I forget. I think we did an anatomical ultrasound. So we can't really use that for dating. That is not an acceptable form of dating. That's plus or minus 2 weeks at that point, right? It's not used for dating. So we have bottom line what she's due. So her due date comes and goes. She's 40 weeks. She's 40 weeks and 2 days. She's 40 weeks, 4 days. She's 41 weeks. She's 41 weeks and 1 day. She's never gestated this long before. She has a history of large babies. Each of her babies went from 8 pounds to 9 pounds to 10 pounds. I caught her 10-pounder. 8-pounder was a C-section. 9-pounder was with us, but we transported and she had a vaginal delivery of a 9-pound baby. Then her 10-pounder, successful out of hospital birth, 10-pound baby. Now we have, and they're all 40 weeks. Now we have this baby. We're 41 and 1. We have a history of these babies getting a pound bigger each gestation. Potentially we're looking at an 11-pound baby. Goes in for her post-dates testing. Her amniotic fluid is beautiful. She gets a 10 out of 10 on her BPP. You know, we think, okay, well, we're going to have a baby sometime soon. She gets to 41 and 3. We still have no baby. We have post-dates testing scheduled for the next day. She goes get some chiropractic care. She's feeling labory. She's starting and stopping. She's having some evenings of contractions. And we're making preparations. Perhaps there's going to be meconium in the fluid, which, you know, the baby got a 10 out of 10 on its BPP. There is some particulate matter in there. We don't know if it's meconium or not, but we're progressing forward. There's nothing wrong. No reason for an induction. There's no medical indication. They've been given the opportunity for a pharmaceutical induction if they want it. They fully know and are making an informed decision of saying, nope, we feel and we trust and we're going to stay pregnant. And she went into labor at 41 and the night of 41 and 3, delivers her baby the morning of 41 and 4, and had the smallest baby of all of her gestations. This baby was covered in vernix, which is that white waxy stuff that is kind of an indicator of gestational age. There was no meconium in the fluid, covered in vernix, and her smallest baby to date. So, why didn't that baby come sooner? It just wasn't ready. It's so every day you go past your due date does not mean your baby is getting bigger and bigger and bigger. It just means your baby's not ready yet. And we trusted and we did all the appropriate post-dates testing and we did all, you know, we were doing all the monitoring that needed to be done. There was no medical indication. And this mother had the easiest birth of all of her babies as well. And it wasn't because it was her fourth. It was just because this baby was optimally positioned. Ultimately, when she finally went into labor, this baby was not optimally positioned up to that point. This baby was in a posterior position. Her pelvis was sort of out of alignment. There were a lot of factors that needed to go into place to make this an optimal vaginal delivery. And she successfully delivered this baby without any complication. And this was not a post-dates baby. So the point is, just because your due date comes and goes does not mean the baby is late. It just means it's not your baby's birthday yet. The fruit's not ripe. So remember, you have a season of when you're due. You have this 5-week season, and some babies will ripen faster than other babies. And it doesn't mean that they're getting bigger and bigger and bigger. My first baby was about, I think I went into labor 12 days post-dates. I delivered at 14 or 13 days post-dates, and he was 7 pounds 4. He was a little peanut. And my second baby came on his due date, and he was 1.5 pounds bigger almost. And he came significantly sooner than his brother. But he was way bigger, and he was fine, and he was easier than the first one. Seconds are easier than the first ones. But, you know, it's just, don't get stuck in your head with every day I go past my due date, oh my gosh, my baby's just getting bigger and bigger. And you'll hear that from your community. Big baby, we need to induce. The evidence does not support that. The evidence in the medical literature says there's no indication to induce for suspected large baby. There is a study that came out through Evidence-Based Birth, which is a wonderful website. We're going to add that link to the bottom of this Facebook Live. We'll add it to our podcast. It's a wonderful, wonderful resource. Join her, subscribe to her newsletters, read her stuff. She does really, really good work, and it's very neutral. And she did a study, and there's no evidence to support induction for suspected large baby. I believe that there's, I'm sure, resources on there as well for this myth of the due date. So be informed. Know to ask questions. If you're consenting to an induction, the questions you want to know is, what is my amniotic fluid index? What is the medical indication for my induction? What is my Bishop score? How long can I anticipate my induction taking? Just so you can set yourself up and you can be prepared. We're not saying don't induce your labor. Saying it's an option. If you're done being pregnant and you get to 40 weeks and 3 days and you are just stressed out and you just really need to have this baby, then that might be an appropriate choice for you. There could be some family situations going on where your partner has to leave town and you really need to have this baby right around your due date so that your partner can be in town and spend some time with you, right? There's so many factors that might inform whether or not you want or choose to be induced, but make sure you have the information. There's a question.
I have a question.
Yes.
So I was induced, but I had a doula, thankfully. My
Yes.
first one, not with you. My second one was with you. And she had talked to me a bit before I was induced about kind of a domino effect that can happen
Yes.
when you're induced.
Cascade
Can you talk
of
about
events.
that?
Yeah, so what Kelly's talking about is there's sometimes a cascade of events. And you probably have heard about this. So if you go in, it's an appropriate reason to go in, right? Amniotic fluid is low and we need to, it's this placenta's done working and it's time to get the baby out. Totally appropriate choice. So you go in, you start your induction. Generally, they'll do some kind of cervical ripening medicine like Cervidil. I don't remember what the generic name of that is, but anyway, it's a little suppository, not misoprostol, or Cytotec. I'm talking about Cervidil, which is this suppository that they put into the vagina that softens the cervix. It sort of gets everything ready, gets you going. And you'll generally do that for 12, maybe 24 hours, depending on the condition of your cervix. And then generally they'll start Pitocin on a low dose Pitocin drip, and then they'll double that dose every 15 minutes or so, depending on your doctor's protocol. And they'll double the Pitocin until we get into an active labor pattern. Doesn't mean you're dilated to 6 where you're in active labor, but you're getting the contractions into an active labor pattern. So often you're on a monitor, which you should be. It's totally appropriate to be on a continuous fetal monitor when you're being induced to make sure that it's safe for the baby. So you're restricted somewhat in your movement. Of course, you could be sitting on a ball, you could be sitting in a chair. Some hospitals have wireless monitors, which are awesome, so you have a little bit more freedom. There's a wonderful hospital up north at UC Davis, Sutter Davis Hospital, where you could even be induced in a tub. They do water births there. It's the only hospital I know of in California where you can be induced and still be in the tub, which is super great. So there are potential for mobility, but sometimes you don't have a lot of mobility, where you're in the bed, you're on the monitor, and now it starts that cascade of events where you go in, you start Pitocin, perhaps they break your water, the pain becomes a little bit intense and you don't have a lot of ability to manage your pain, so now you get an epidural. So now you have an epidural, you now have a bladder catheter, you're very restricted in your movement. Perhaps this baby turns into a posterior position because you're somewhat restricted in your movement. You can't help this baby stay anterior, and you can't really help the descent of the baby. So now we have a labor that maybe stalls. Now we have to increase the Pitocin even more. Now we either have a baby that goes into distress because the contractions are going on and it's stressing the baby out. Fetal distress is a reason for a C-section. Arrest in your labor, you get to 6, 7, 8 centimeters. You don't dilate beyond that. Now we need a C-section for failure to progress. So what came first, the induction, or would this have happened without the induction? But we don't really know because of what we call this cascade of events. Did I answer that question?
Yeah.
So I'm not saying you shouldn't get an epidural with the Pitocin induction. Sometimes you really need that because of you need some help with the pain management. But just be aware of what this cascade of events is, and try to make some choices where you try to avoid those interventions as long as you possibly can, as long as it's safe for you and your baby. So hopefully I've answered that question.
We have another question. Sarah asks, she said, I have a friend that was induced because the doctor claimed she had too much fluid. Is that a thing?
Yes, that is a thing. That's called polyhydramnios, and sometimes that is an appropriate reason for an induction. We have had to risk some moms out of our care actually for that condition, polyhydramnios, because it does have some risk factors associated with it. There are so many questions that I would ask about that polyhydramnios. My question would be, what was the number? How many weeks gestation was she? Did they make some dietary restrictions? Was she gestational diabetic, uncontrolled? Was she on insulin? There are so many factors that go along with that polyhydramnios. And sometimes it is appropriate to go in and be induced so we can control. Actually, if that water breaks, there's a higher risk of what's called a prolapse cord. We took someone into the hospital not that long ago. She wasn't polyhydramnios, but this baby's head was so high out of the pelvis, she was almost completely dilated. She was like 8 centimeters, and she had this big bulging bag of water, but the head was nowhere behind it. And we were concerned that if that water broke in an out-of-hospital setting, that the umbilical cord would come in front of the baby's head, and we would have a 911 emergency. So just for safety reasons, we opted to go in and have the water. Well, the water was broken while the doctor was doing a vaginal exam, but she was not intentionally breaking the water. This bag was ready to break. But thankfully, the doctor's hand was in there that could guide this head to make sure there was no prolapse. So that might very well be an appropriate reason for an induction. But there are a lot of questions that go along with that, and lots of monitoring that we want to watch for. And there can be some issues with that. Polyhydramnios can cause a prolapse cord. You also have a higher risk of a postpartum hemorrhage because that uterus is distended. So after the baby is born, it may not contract very well, and that mother has a higher risk of bleeding too much after the baby's born. It can risk her for a uterine rupture. There are a variety of things. So that might be appropriate depending on some criteria. So there's my answer to that one. If you have any other questions, please ask them here. We love to engage in conversation. If you have friends that are pregnant, we ask you to invite them to follow our Midwife Monday. We didn't do one last week because I was getting a cast on my hand, so I was a little bit busy. And spring break was happening and all those good things. But we are back, so invite your friends to join us. You can follow us on YouTube as well. You can join our channel.
And the podcast.
Our podcast. And the more you comment, the higher our ratings go, so the more people see us. So do comment below, like us. Also follow us on Instagram. SCV Birth is our IG account. And we're going to be doing some really fun IG stuff this week with some takeovers and giveaways, and that'll be super fun. So I hope everybody has a great Midwife Monday. It's supposed to be really hot out there, so all of my pregnant people, make sure you're hydrating really well today. Try not to be exercising out in the middle of the day. I do believe it's supposed to be about 90 plus degrees here in the valley. So hydrate, and maybe save your walk for once the sun starts to go down and it cools off. Okay? See everybody next week. Thanks for joining us.